Good morning. Thank you for joining us as we talk about one of my favorite subjects, of course, plantar fasciitis. I'm Dr. Meredith Warner, founder of Warner Orthopedics and Wellness in Baton Rouge, Louisiana. And I've also invented the Healing Soul, and I'm founder of Well Theory, which is a natural medicine product. And all of these are extensions of my overall philosophy, which is to help you help yourself, or to empower you with your own health. That's me. This is my clinic in Baton Rouge, this isn't even really inclusive of all of the services we offer, in the goal of improving people's overall musculoskeletal health first, and then their overall well-being and ability to live their lives second, and really part of first. Health is wealth and health is happiness. So we're here for you, and we're just trying to make lives better every which way we can that's safe and effective. So basically, what you'll find at my clinic at Warner Orthopedics and Wellness is a very awesome team. We have amazing physical therapists. I have an amazing PA that does aesthetics. We've got great staff. I've got an amazing PM&R, physical medicine rehab doctor who does the best electrodiagnostic studies really in the state, and likely very high up nationally. I've got an awesome podiatry partner. There's me, and we're all here just for one simple mission, which is to improve your health and your wellness. This is our clinic space. So I run a different model than pretty much any orthopedic surgeon. My physical therapist and I work together on a daily basis. The gym is really part of my clinic. And so we're popping in and out and talking to each other all day long, because I'm a big believer in the human body as a beautiful machine. And really, if you can make that machine function the way it was meant to function, most pain goes away and most things just start happening naturally. Physical therapy or physical medicine is really part of that. So that's a big part of my philosophy. And so we work very closely together. And then just visualizations of the rest of our clinic. And that's my podiatry partner on the bottom, Dr. Kyle Lindo. And he's been an awesome addition to our team. So today we're going to talk about my favorite subject, one of my favorite subjects, because I do love natural medicine, which is plantar fasciitis. So next slide. I'm waiting for my technical glitch. There we go. What is plantar fasciitis? Well, that's a great question, because there's been a lot of misinformation or misnomers. The name itself is not really indicative of what it truly is. We'll talk about that in a minute. Basically, the plantar fascia is a webby ligament. Fascia is sort of just real thin bands of fascial tissue. Think of kind of the gristle that surrounds a steak, I guess, would be the best way to visualize it in your head. It's a thin, strong band of tissue, almost like Tyvek, that's on the bottom of your foot. And the plantar fascia specifically goes from the heel, and then it goes on the bottom of the foot and then interdigitates vertically with all the toes. And so it's effectively the tie rod to an arch, okay? So your foot would fully collapse with every step were it not for that tie rod, the plantar fascia. So it's integral to the foundational, I guess, ability of your body to function as a unit. It's used all the time, every day, and obviously is under a lot of stress, both from lifestyle, chronic disease, diet, oxidative stress, but also mechanical load. So the ligament, and I'm going to call it a ligament because it connects bone to bone, but really it's fascia. It essentially absorbs shock and redistributes tension and helps support and tighten the arch during push-off. So again, it's integral to motion, it's integral to stance, it's integral to really being able to be in space and maintain our position in space. Plantar fasciitis, we think, really nobody knows quite yet at this point, why does it really happen and to whom will it happen? Tons of research has been done on this and nobody really knows the answer. So I'm just going to tell you sort of my philosophy based on everything I've done, all my research and reading and my clinical experience. This statement here, that it's from repeated overstretching and tearing, is sort of a simplification of what's really going on. Newer data is showing that there's evidence of chronic inflammation markers within the substance of the plantar fascia. So it technically might be an inflammatory condition, but it's not acutely inflammatory like we always think of tendinitis is. It's more like it's a long and slow brewing degenerative process. We say that it's because of overstretching and tearing, mostly because that's easier to conceptualize and understand. So repetitive injury from exercise is one reason people bring up all the time. So for instance, runners get it a lot, but non-runners get it. So it really can't just be from that. And then genetics, but all things are genetic. So that's difficult to say too. But basically we're starting to think, just like everything else in the human body, it's probably a result of chronic inflammation and oxidative stress in combination with a heavy mechanical load. So that's just not a good combo. And then you'll develop the pain at the attachment point of the plantar fascia, which again is the tie rod to a high tension arch. So again, it's essentially just the name of a condition, whatever the reason, that causes pain here, usually on the medial side of the heel bone, that is on the inside aspect of the bottom of your foot and the heel bone. Now, some people will get it mid-substance. Some people get what are called plantar fibromas, which are like thickenings of that fascia, and sometimes those hurt, sometimes they don't. Some people will get it distally out by the toes, but by and large, if it is true plantar fasciitis, you're going to feel it more or less right here. And itis, again, is the Latin derivation of inflammation. It denotes acute infection or acute inflammation. That's not really the case here, but there is evidence that there's chronic inflammation. This image shows you the plantar fascia on the bottom of the foot, dissected out. Hopefully it's not too disturbing. The ligament goes from the bottom of the heel, you can see it right there, extending forward and then spreading to interdigitate. You see how thick and strong it really is. I mean, it's an amazing structure if you think about it, what it's asked to do every single day, all the time, and it does it for lifetime. And it's really not that big, but it looks pretty good on this picture. This other image just shows load on a pressure sensor to show you sort of why that mechanical load might impart some pain in an area that has chronic inflammation and oxidative stress to begin with. So I think of it as a fasciosis, not a fasciitis. I don't really think of it as an inflamed condition unless you're talking about chronic inflammation. That's a whole nother talk, and we've talked about that before, for instance, in my talk about the Mediterranean diet. If you look in these images, the left picture denotes a microscopic view of a degenerative fascial sample. The right side shows normal. So normal should be smooth, nice linear bands. There should be good, healthy cells inside that are going to be making the matrix that creates the fascia. The left side has this disorganized, irritated area that obviously has no functional use. And then what's more, what this picture doesn't show you, is at that point, it starts to produce things like substance P and other proteins that cause pain. And that's the problem. It happens, 15% of episodes of foot pain are from this condition. We think it's up to 9% of all running injuries. 2 million people a year in this country go see a doctor about this. And obviously there's a fairly decent economic burden from this problem. And it really comes down to that, just that little bit of disorganized fascia. So the histologic or microscopic findings of plantar fasciitis, and this ultrasound image, look at that while I tell you everything that's going on at the cellular level. The left picture, you see, it's an inverted heel, okay? So you're looking at it like this. So that white line coming down and going like that on the bottom of the screen with all black under it, looks almost like a hill. That's the heel, okay? So the guy's got the ultrasound here doing this. The fascia is the band of tissue coming like this. So there's two thin white lines coming off the little lump of the heel. Nope, go up. There. Go forward, go to the right, go to the right, go to the right. Keep following the line. There you go. That's the plantar fascia. And you see it on the right side, they've outlined it in yellow where it's thickened and damaged. So the left is a normal plantar fascia. The right picture is plantar fasciosis or plantar fasciitis. So the body's response to abnormal forces and weak dysfunctional tissue, because remember from the last picture, I showed you how it was useless tissue. The body's response to that is to make more of it to achieve the same function. So that's why Achilles tendons that have tendinosis get really thick and big. That's why you grow spurs with osteoarthritic joints. Things that are weaker, the body decides, well, it's not doing what it's supposed to do, so I'm just going to make it bigger until it gets right. And that's what that shows you. So you can do ultrasounds of these things. It should be 4 millimeters or less. If it's over 4 millimeters, you can be reasonably assured that there's some degeneration going on. Myxomatous degeneration is happening. That's where it becomes gloppy and filled with liquid. Connective tissue calcium deposits occur in this. You get the disorganized collagen fibrils that we already talked about, and you saw that picture. Chronic inflammation, which we talked about. Angiofibroblastic hyperplasia, what that means is new blood vessels are forming within the fascia, which should be avascular. There really shouldn't be blood vessels in there, but because there's so much nonsense going on in this irritated tendon that's under oxidative stress, it grows new blood vessels in a futile attempt to heal itself. Chondroid metaplasia, that means that the fibrocytes and the tenocytes are starting to convert and go down a different wrong growth path towards bone. That's when you get spurs forming as opposed to fascia. And then collagen death or necrosis. All of this is going on in those pictures to make that thicker and damage and to hurt. So what does it feel like? I'm sure you guys all know, or you probably wouldn't be listening to this. You know that it feels like a quote unquote stone bruise. It feels like you're literally stepping on a stone here. It usually hurts with periods of cool down. So if you drive for a really long distance, you get out of the car, you take a step, that hurts. After you wake up in the morning because you've been, laying on a bed all night, everything's relaxing, you take that first step, that hurts. So it's usually painful after extended periods of rest, and it's usually only in this one spot. It feels like a stone bruise. It'll get better with time. As you're more active, because you loosen things up, the body releases its own natural painkillers, endorphins, and natural endocannabinoids and whatnot. You'll start to feel better, but then the minute you let it cool off, tighten up, step on it, it hurts again. So that's essentially what it feels like. And then who gets this? Well, really, probably literally everyone, unless you're a really young child or like a really, really old person. But by and large, the people that present to physicians' offices, now, of course, that doesn't mean other people aren't having this pain. It's generally people in the working age group, right? 40 to 60. So it's people that are active, they're working on their feet all day, they're busy, they're under stress, they're probably not eating that great. And so it's generally that age group. We think, we think, meaning the literature always says obesity and pregnancy causes a lot of fascial problems, and that's really a hormonal response, not so much the weight load. And then the obesity, again, leads to chronic inflammation. So again, it's not so much the weight, because somebody that wears a 100-pound weight vest all day may not get plantar fasciitis, but somebody carrying 100 extra pounds of adipose could, because the adipose cells produce chronic inflammation. Again, those who spend long hours on their feet, obviously you're going to have more foot pain in that condition. And then runners, and a lot of that has to do with the biomechanics of running and what you're wearing and miles and recovery, et cetera, et cetera. But it is pretty common with runners. Oh, we're getting a lot of questions. All right, we're going to take a question break.
So, Joe Paula wanted to know if, a couple things. Wants to know if you get this, does it cause bunions? Is it related to bunions?
So we had a question, I think it's a two-part question. If you get plantar fasciitis, does it cause bunions and or is it related to bunions? I don't think it causes bunions, but it could be related in that, remember I told you the plantar fascia starts on the heel, comes on the foot, vertically interdigitates with the toes. Well, the main insertion point's the big toe. And so that engages what's called the win-loss mechanism, where when you push off and go up, the big toe will actually tighten the plantar fascia that supports the arch. Well, if you have a bunion and your medial column is incompetent and this is deviated this way, obviously that changes the biomechanics of your plantar fascia and it can lead to heel pain.
And then are there any types of shoes which ease the discomfort?
The question is, are there any types of shoes that ease the discomfort? Honestly, there's a lot of shoes on the market, a lot of different brands. I have my own device, of course, so I'm going to be biased about the flip-flop I designed to treat this, the healing sole. But that's a flip-flop, and that incorporates muscle strengthening of the foot and other reasons I like that. Closed-toe shoes. I love Danskos. I wear them all the time if I'm not wearing the healing sole. I think Kuru's is a good brand. For sneakers, a lot of people like Ultras because they're zero drop. I carry those at my clinic. They're amazing for this condition. And then Hoka 1-1s, which are really cushion. The problem is you don't want to depend on cushioning. I'm going to talk about that later because it's a false sense of security, just like steroids are. But it comes down to you, who you are, what you like to fit in, because sometimes you can actually modify how your foot uses a shoe with an insert, okay? So you can wear any shoe you want as long as you have a good insert. So it's a difficult question to answer, but there are a bunch of things on the market, and some of them are pretty good.
Deb Johnson, I've had this from my 20s, now I'm in my 40s. I first noticed on my job as a personal trainer, I have high arches.
Okay, this is a long question. Let me summarize. This is somebody who's a personal trainer. She's had pain since her 20s. She has high arches.
And she's tried everything.
Tried everything.
Surgery.
Oh my gosh, she's even tried surgery. So
Still has it. She's 5'4", and she's usually normal weight.
okay.
And she gave up, and she only wears one type of shoe now.
Okay, so this unfortunate individual is a normal BMI or body mass index, obviously very active, tried everything, even up to surgery, and still has foot pain. So I will tell you that I see that patient, not that one specifically, obviously, but that sort of patient all the time. They find me after they've been treated for years and years and failed everything else. And I'll tell you, in a lot of times, those cases, it's not plantar fasciitis. There's usually another diagnosis. And I find that a lot of times things that mimic plantar fasciitis have been overlooked. And that, it makes me sad to know that you went as far as surgery and it still didn't work, because honestly, in my opinion, based on my education and my philosophy and if it's true plantar fasciitis, it should respond to non-operative treatment. If it's something else, like let's say a calcaneal stress fracture, tarsal tunnel syndrome, Baxter's neuritis, there's a bunch of different things that can cause heel pain. That's not going to respond to any of your normal treatments. And then unfortunately, a lot of those are underdiagnosed or missed, and people go down that wormhole of plantar fascia treatment to no avail. And that kind of makes me sad. All right, let's move on in my talk. Oh, wait, we have another question? Hold on.
After wearing your flip-flops a few hours, I move from relief to discomfort. Is that normal?
The same person? Oh, okay, another question. Somebody said that sometimes when they wear my flip-flop, the healing sole, for a few hours, they move from relief to discomfort. Is that normal? I would say yes and no. Again, I don't know who you are. I haven't put my hands on your foot. I haven't really examined you to tell you what your actual diagnosis is. But I find that you really should switch shoes anyway during the day. I tell all my patients that. I don't want anybody wearing this all day long. This is a recovery shoe. It's designed to help your body heal itself. But really, you should be using different shoes throughout the day so that you use different muscles and you stretch different ligaments, et cetera. So I always tell people to wear it for a few hours a day and go to something else. So yeah, it can be normal. But again, I don't know what your actual exam is, but I don't think anybody should be wearing this all day long. Really, a couple hours should be enough every day. All right, now we're gonna move on. But we'll take more questions, so don't be shy. All right, so the risk factors. So again, this goes along that question of who gets this. Well, again, remember I told you the science/MD/DO/DPM community, nobody really knows. So take all this with a grain of salt. Certain sports lead you to it. Think of cleated sports, running sports, alignment issues. So remember, one of the questions was very high arches. I find that posture actually puts you at greater risk because this is such a tight tension band than the flat-footed people. A flat foot is more like this, more accommodating to the plane of, I guess, weight bearing, but again, not as efficient of a foot as this is. And that has to do with the way these joints lock into place with a higher arch. Length of time on the feet. And, I think this goes back to physical therapy and sort of my philosophy about the human body as sort of a beautiful machine. If you're on your feet for a long time, especially if you're in a tight work shoe that's soft and squishy, your foot's kept in one position all day long, you're going to fatigue the muscles that you are using because you're not using all the muscles. And when you get fatigue of the core muscles of the foot. Think of it like your spine. You have core stability of your spine. When that gets fatigued, that's when the big muscles overpull or pull incorrectly and you get back pain. That's why there's always an emphasis on improving core strength for low back pain. Same thing with the foot. If you get fatigue in your core muscles of the foot, well, then you're going to have drop in arches, you're going to have stress, you're going to have overpull, and that's when you're going to start to get pain. So I think that's why the length of time matters. Pregnancy, we talked about hormonal changes. Pregnant ladies will get carpal tunnel syndrome, trigger fingers, tarsal tunnel syndrome, plantar fasciitis, low back pain. That the hormones just rage. But the reward at the end is always awesome. And then overweight, we talked about chronic inflammatory change, chronic inflammation, the burdens on the body with oxidative stress. And then poor shoe choices. So a lot of people think of price first with shoes, which is probably not the way to think about it, because at the end of the day, if your feet hurt, that's going to cost you a lot more than a decent pair of shoes. And so again, back to that first question, I like Dansko's, I like the Healing Soul, Kuru's a good brand, Ultras, Hoka One. There's a lot of different good brands, but you need to make sure it's a good structural shoe that's going to last a while and follow certain principles. It can't just be a squishy shoe with like memory foam, because that goes away and depletes over time. And then you're left with essentially nothing at the footbed. Okay, so running, we talked about this, a common cause of plantar fasciitis. I put this slide in to remind me to talk to you about the different philosophies of minimalist running, heel strike, toe strike. There's a lot of literature out there that espouses mid-foot or toe strike running to reduce the incidence of injuries from heel strike running. And then there's a lot of literature out there that goes the other way. Who's to say? I think if you're a serious runner, you probably need to go get a gait analysis like this gentleman on the bottom here, and then really see how your hips are controlling the long leg axis alignment, because your hips have to do a lot with running injuries to the foot. That often gets forgotten and neglected, not by my physical therapist, but by a lot of people. The hip is hugely important to how your foot feels because it controls the long bone rotations. But running is a super common cause of plantar fasciitis. But what a lot of literature doesn't show you is, how new to running is the person, how much time had they taken off, what did they eat the night before, what's their oxidative stress, how many inflammatory markers are running around in their system. There's just so many variables we don't know. All we know is a lot of runners complain about heel pain. And it might be what I talked about before with the foot core fatigue. It might just be as simple as that. Or it might be jogger's nerve, which is really common, where the medial plantar nerve gets compressed by the abductor hallucis muscle, and that mimics heel pain. And I think that's missed a lot. So what about the heel spur? Everybody who comes to see me in my clinic says, oh, well, my other doctor told me I had a heel spur. Well, okay. But just so you know, heel spurs matter, because if you do have plantar fasciitis and you have big heel spur, odds are your pain is pretty significant. But in general, there's enough studies out there that show that people with no heel pain have heel spurs, and that a lot of people with heel spurs don't have heel pain, that we can only say it's somewhat correlated. It's definitely not causative. But we also know that the heel spurs form from that metaplasia, that chondrometaplasia we talked about with the calcific deposits, from sort of overpull or traction. So it is related with fascial integrity and biomechanical issues. And you can see on the scoring system on the bottom, that's from one study, that over time you may have a bigger spur, and that's been associated with higher pain. But we can't to date say it's causative. So don't hang your hat on the fact that you have a heel spur, because plenty of people have heel spurs and don't hurt. And I treat pain, like let's say Achilles tendonitis. I can treat Achilles tendonitis with a minimally invasive surgery in the mid calf to just lengthen the gastroc part of the Achilles. I don't even touch the heel spur. In almost every case, the pain just goes away. They still have the spur. So is it the spur that hurts? No, I think it's the degenerative tendon material around that. And once you reduce that stress, it feels better.
Tell everyone to check the comments, to go to hit the link in the comments.
You're supposed to go to the comments and hit the link. There's a video coming out, I guess, for a video we're going to show in a minute here. Oh.
The feed on the Inventor's live page is going out, but the one that's working is on Orthopedics. And they need to click the link to go to Warner Orthopedics
Oh.
Facebook page.
Okay, you have to click a link to go to the Warner Orthopedics Facebook page.
Because the Healing Souls is not working.
Oh, the Healing Souls link is not working. Okay, so click the link that's in the comment section right now to hear the rest of the talk. We're going to send you to a different Facebook page.
The Healing Soul is not working.
The Healing Soul link is not working.
There's a pause on the Soul line. Okay, I'll pick up.
Well, that's terrible.
No, this is the
I'm sorry.
technical difficulties.
Okay. All right. So how can you prevent plantar fasciitis? Well, this slide is in here because a lot of people ask me this. I don't have a good answer for this because you're going to get it or you're not going to get it. And again, we don't know why people get it. We don't know who's going to get it. So how can we tell you how to prevent it? But I'm going to say sort of the general thought processes of this. I don't think you should wear squishy shoes all the time because the foot was meant to be on a structured plane. If you think about it, we evolved barefoot. Nobody was walking around in memory foam or soft-celled foam, and the foot needs to have structure to function, all those biomechanical linkages we talked about, like the wind-loss mechanism, and to strengthen the core muscles of your foot. If you're wearing a tight, or not tight fitting, if you're wearing a shoe that's closed toe with a soft, squishy thing and your foot never moves during the day, I mean, really, what are you doing to the foot muscles? You're essentially forcing deconditioning, like your foot binding almost. Again, avoid shoes that strain the foot, opposite of that problem, right? You could avoid high heels, but actually, some people feel better in high heels, and you might think, well, that doesn't make sense. But the plantar fascia attaches here on the calcaneus, the Achilles attaches here, right? So if you wear a shoe that does this, you're automatically lessening the tension on this side of the heel, and then this side feels less tension. So paradoxically, wedges and heels, a lot of people tell me feel better. But it's a deceptive thing because then they keep wearing those wedges in the heels, and what happens over time? The Achilles contracts and gets tighter and tighter. And so every time you try to be flat and be normal and natural, it hurts even more. So it's, again, a self-fulfilling prophecy. And we just have to fight that tendency. Or if you're going to wear heels all day, like let's say you have to for work, you really should have a really good dedicated program to stretch your heel cord and stretch your plantar fascia every night at least. Arch supports, plus minus. If you have super high arches, you don't really need help with arch supports. If you've got flat feet, on the opposite end, if you have a flexible flat foot, meaning it's pretty limber, you may do well with an arch support because it might put your foot in the proper position to make everything work better. If you have a rigid or semi-rigid, arthritic kind of a flat foot, you try to wear an arch support, that's going to kill you. And then if your plantar fasciitis is not really plantar fasciitis, but rather a nerve compression, the medial plantar nerve, that so-called jogger's nerve, sits right where an arch support pushes. So a lot of people that have nerve-based pain that has been misdiagnosed as plantar fasciitis get prescribed inserts, or they go to like the Good Feet store and they buy the $1,200 insert or whatever, and they end up feeling worse. And that's probably why, in my opinion. And then avoid over-exercising. Well, what does that mean? I mean, there's 100-year-old people running ultra marathons right now. I don't know what over-exercising means. That's probably personal. I think that probably means over-exercising for what your body has been conditioned for. Because for me right now, because I work too much, I think if I try to go run a mile, I would get injured. Now, I know people that if they go run 26 miles, they're going to be like, can I run 10 more? So that's a personal thing, over-exercising. And then adding pressure to your feet. Are we good with technical? Everybody went to the Warner Orthopedics link in the comment section? All right. We have a question.
She had heel pain that we're describing for about a year. She didn't do anything and then it went away. But then she was packing her house in flip-flops and then the heel pain suddenly came back. I'm guessing it did something to exact.
Okay. So this question is somebody that had heel pain, did nothing, and it went away. Then they were packing their house, which we all know how much work that is and stressful. And they were wearing flip-flops. I'm going to guess not this flip-flop. And they developed heel pain again. You know, the natural history of plantar fasciitis is this. Literally, if you did nothing, 95% of people would get better. So that means 95 out of 100 people with plantar fasciitis, if you just did nothing, went about your business, it'll get better. The problem is it hurts that whole time, and it can take anywhere from a year to 2 years to get better. But the natural history is that it will get better. Why? Because the body always is trying to heal itself. And the other part of the natural history is it comes back. So it's recurrent. So probably there was some sort of biomechanical overload, or you stepped on something funny, or you twisted your foot just right in your flip-flops, and then it decided to manifest itself. But odds are it was going to come back anyway, whether you were moving or not at some point, because that's a natural history of this disorder.
Just a lot of comments, like my PF is lessened, but now I have very sharp,
Okay.
sitting pain on the rim of the heel.
Okay. Okay, got it. On the rim of the heel? Okay, so I got another comment from a Mary who said she had plantar fasciitis pain, then it went away, and now it's on the rim of the heel. I presume she means laterally out here when she says rim of the heel, because again, the plantar fascia pain is usually on the inside, so if that went away, it must still be on the lateral. Again, I see that a lot. People come in and they say, no, it doesn't hurt on the inside. Everybody tells me that. It hurts out here. Well, guess what? That's probably the lateral plantar nerve or the Baxter's nerve that comes around and ends over here. So sometimes that, again, is a misdiagnosed condition. All right, so let's talk about treatment now. So the bottom on this slide is my favorite, and I see this a lot. Self-diagnosing or ignoring the symptoms and hoping it'll go away. Well, again, you're not so wrong. I just told you that. But you'll have to wait a year or two for it to just go away, and it's probably going to come back. And then people seem to love going to see people like me to get sharp objects stuck in their foot. I don't get it. I don't understand it. But people have been duped to believe that this is a good idea. You know, I get it all the time. People get angry sometimes if I tell them that steroids aren't good for them, because they've been so ingrained to believe this because the medical community does it so much. It's very cheap. You can bill for it. You can bill for it repeatedly, but there are problems, and I'm going to talk about those. I think there's better ways to treat the human body than jamming steroids in it or operating, and I'm a surgeon. I love operating, but I've grown to believe that there are better ways in a lot of cases. So again, let's talk about everybody's favorite, steroid shots. Oh, I got a steroid shot and it went away and it never came back. Great, but remember I told you 95% are going to go away anyway. Steroids do produce short-term relief, don't get me wrong. 100% they're going to make your pain feel better short-term. Not in every case, about 70, 80% of the cases, but that's like saying Percocet gives you short-term relief, or Opana ER, or a fentanyl lollipop. Yes, it does, but is it worth the side effects? Probably not. It does produce a short-term pain relief, and technically a short-term, and when I'm talking short-term, the studies are like a month. So you might get a month of relief, a month of increase in function. However, the steroid will cause damage to tissues, and I'm going to explain why. I put these two pictures here to show you the fat pad of the heel, which is one of the victims of steroids. The fat pad it's brown fat. So fat under your arm on your belly is white fat, we call it. These are obviously lay terms. Brown fat is a honeycomb structure, very complicated, very designed for compressive load. So you have it on the ball of your foot, right here for compressive load. You have it on your heel. If that fat pad gets destroyed and goes away, it is totally irreversible, never to be replaced. You can inject with fat cells, and I do that for people sometimes, but it's never as good as your natural fat pad. Steroids cause fat necrosis. So if you inject steroids in there and you do it enough or once just the right way, you could kill that fat pad, and then you've got a patient that has bone, nerve, and skin, and that is it. And talk about pain. That is painful. It accelerates bone loss. People that get repeated steroid injections, for instance, epidural steroid injections in their spine and whatnot, end up with osteoporosis. You can get dead bone, avascular necrosis of the hip, and it causes rupture of the fascia. Some studies say about 10% of people that get a shot, 1, 2, 3, however many, get a rupture of the plantar fascia. Most of the athletes you hear about, worthy. But in some cases, it's all you've got left. I get that. Okay, so what are the risks? So this picture on the top right, That is a microscopic, like super microscopic picture of fascia. I just wanted to show you that, how intricate, complex, and amazing fascia is if you think about it. That webbed material is throughout your entire body, holding you together in space and giving you tension and compression where you need it to move in space and to function as a human being. And it comes down to that. So if you disrupt that at the microcellular level, what are you doing macrocellular or macroscopically? You're doing a lot, and you need to think about these things. A single injection of steroids will induce failing strengths it'll cause failing strengths to decrease by about 35%, meaning it takes less force to tear the fascia when you put steroids in. Cystic spaces in the bone and the tissue around developed or holes, collagen necrosis, dead collagen. Give a steroid shot, you're basically killing collagen. Your fascia is known to be weak for at least 2 weeks. That's probably your highest risk of rupture. So if you get a steroid shot, you really should lay off activities for 2 weeks after that. Well, what's the point of getting a shot to increase your function if you're not supposed to do anything after because you might rip it? Your cellular metabolism is suppressed, your mitochondrial health. I talk about that a lot in other talks. Collagen synthesis, or the ability of the body to produce more collagen, which is the building block of really everything. So wrinkles are from a lack of collagen. Damaged tendons is from a lack of collagen. Well, you give a steroid shot to treat a collagen problem, but you're killing the collagen and preventing the body from making more collagen to replace the collagen you just killed. Proteoglycan synthesis is suppressed. Now, this is the element within tendons and cartilage that holds fluid and gives it compressive strength and flexibility. So you basically drying things out. And then again, all of this to get maybe a month worth of pain relief. And we're going to talk about the cost of this down the road. And I'm just not sure it's worth it. And remember, steroids cause their change by going to the nucleus and telling the DNA to change its behavior. So you're dramatically changing cellular function of the collagen, the tenocytes, the chondrocytes when you get steroid shots. Ruffled feathers. I always do when I talk about steroids. I told you people get very upset about this.
Why on earth could I still offering the steroid shot? Does it keep coming back? I had one in December because the podiatrist recommended it.
Okay, so this question is, why on earth are podiatrists still recommending steroid injections if they cause all of this? I will tell you, it's not just podiatrists, primary care doctors, orthopedic surgeons, the medical community at large, to include the insurance companies and Medicare. Medicare and the insurance companies pay for these. They don't pay for really anything else. They're cheap and you can bill for it. Now, if you're a cynic, sure, that's a reason that it's done. I personally think that most doctors don't really understand the basic science of what steroids are doing to people. Sad to say, but just like most doctors don't understand nutrition, most doctors have no idea about natural remedies. You know, all they know, and a lot of these guys, unfortunately, are stuck in practices owned by hospital systems where they're forced to see 50 to 60 people a day. They're burned out, they're mentally exhausted, and sometimes it's easier and faster to just give a steroid shot and go on to the next patient to meet the quota that their employer is forcing them to achieve. I'm not saying any of this is good, but I don't want to lay blame on anybody. I'm just telling you my philosophy based on the basic science, the research, the literature out there. I don't think steroids are good. I do them in certain circumstances. If there's really no other remedy available, or if I know we're about to do something else where it doesn't really matter about the tissue damage. But I can't speak to why somebody else does it. A lot of physicians and podiatrists love steroids. I have no idea why.
Can you speak about extra tissue in the arch of the foot?
Okay, I think I know what this question is. Somebody just asked a question if I could speak about extra tissue in the arch of the foot. I'm going to guess they're talking about plantar fibromas, which is, again, the fascia extends from the heel to the toes. It's sort of a flat sheet like this, but some people it will thicken and enlarge, and that is, we call it a plantar fibroma. It's a thickening of that region of the tissue, probably for the reasons we talked about, chronic inflammation, combined with a certain type of biomechanical load, signals to the body, oh, this area is weak, let me make it thicker so that it functions at the same level. Pretty sure that's what you're talking about. Most of these are benign. They're not bad tumors. You should leave them alone if you can, because the treatment 99 times out of 100 is worse than the problem.
Right behind the big toe, close to the arch, after a full day of work, it gets tender right at the ball, just before arch.
Okay.
Is that a part of plantar fasciitis?
So the question is, right here, at the end of a long day of work, this person gets pain, and I guess it swells and they feel like a ball. That is part of the plantar fasciitis. It's also part of the sesamoid complex. The sesamoids are two little baby kneecaps under your big toe that make the muscles more efficient. Some people will get a tendonitis right where the flexor makes an insertion on those sesamoids, but the plantar fascia runs there too. And that's, again, the strongest attachment point is the proximal phalanx of the first toe. So one of the sites, it's uncommon, but that is a site to get plantar fasciitis, is at the distal aspect. Most people get it on this side of the tie rod, but some people do get it here. To keep it from going away. Oh. What to do. We're going to talk about what to do, what you can do at home, self-treatments coming on in the slide. And again, I'm not offering medical advice to anybody. I don't want to get in trouble here. I'm just telling you my philosophies. Oh, apparently there's a lot of questions about my flip-flop. Let's talk about that later because I really just wanted this to be a teaching moment, not so much talking about my flip-flop, but I'm happy to talk about it at the end, which I will. But I want to keep going mostly so you guys all understand really everything that goes into this.
As your foot flattens with age, what happens to the fascia?
This question is, as your foot flattens with age, what happens to the fascia? Well, your foot's flattening with age because the integrity of all the structures are not so good anymore. Everything from the bone to the muscle. There's a certain amount of sarcopenia or loss of muscle when we age. The bones get brittle and thin as we age. The fascia becomes less useful as we age. And this all comes down to chronic inflammation and oxidative stress. So I'm a big believer that aging or a lot of the issues with aging can be prevented, if not reversed, by managing chronic inflammation and oxidative stress. So the foot flattening is probably because the structural integrity of the foot is not so good. What you can do, I will tell you, and again, I don't know who you are, I'm not giving you an exam or anything, so it's philosophically what can be done in that case is strengthening the core muscles of the foot, and that's been shown to improve arch height and restore arches. Alternatively, you can do inserts with a met pad, which will help the long axis arch and the transverse arch that goes like this, that a lot of us lose with time. But I would say call your local physical therapist, ask them if they have a good core strengthening foot strength program, and do that. That'll help with balance and everything else. Fall risk is a big problem as we age, so I think that would be a good option. Okay, so again, let's talk about surgery. Everybody thinks, oh, one and done, all problems solved, it's easy. I don't have to buy shoes or flip-flops or whatever. Well, okay. I can tell you in the past decade, I've done maybe 3 or 4 true plantar fasciitis surgeries, again, because most of the times it's misdiagnosed in my opinion. But again, the vast majority should get better with these other modalities and you shouldn't have to do the surgery in my opinion. And I've been very unhappy with the literature, very unhappy with the actual results, because I see people after they've had that surgery elsewhere, they still hurt, they hurt in different places, and they come to me. And of course, that makes it very complicated to fix that problem, which we can, but I wish they would have found me before they had the surgery. Most of the literature, just case series. So for instance, I could write a case series right now on the number of Achilles tendinitises I've treated with a gastroc recession and probably get it published. In fact, maybe I should. But again, that's just a case series. It's my personal case series that I'm writing about. So you as the reader would take it or leave it. Do you trust me? Do you believe me? Do you not? So most of the literature on plantar fasciitis surgery are case series, and a lot of them are historic, like from way back when, like 60s, 70s, 80s, back when people removed the entire plantar fascia. So that's not really done anymore. So you would have to discount all of that literature to begin with if you're even going to start talking about the literature of plantar fascia. Most of the articles recommend, again, wait for a year, which you should do anyway, because remember, the natural history is such that it should get better. What I do, and what I hope other doctors will do for you, is try to speed up or compress that natural history so that you don't have to hurt for a year or more. Surgery may be successful for 70 to 90% of the people in the short term, But that doesn't mean everybody's satisfied. There's a great article that I recently read where sure, 70% said the pain was better, but 50% of the people were not satisfied with the surgery. So is that a good result? I don't really, maybe? It's hard to say. Some people complain of lateral column pain, so the pain moves from here, all of a sudden anywhere on this side of the foot hurts. And that's because the fascia is no longer there to be a tie rod, the loading of the bones changes, and now you've got higher loads where they're not supposed to be or where they weren't meant to be. Flat foot, I've seen that. People come in with flat feet on one side. Well, in their history, they had a plantar fasciectomy sometime in the remote past. Recurrent pain, and then infection, of course, damage to the fat pad, et cetera, et cetera. So surgery might be successful short term, but again, there's a lot of side effects. I think you might want to go into that open-minded knowing. Okay, so here's some literature review of steroids, talking about literature. So here's one of physical therapy versus steroids. This was out of the Journal of Foot and Ankle Surgery in 2019. So they put two groups head to head. One got dry needled at PT, one got steroid injections. The dry needling group ended up with the same pain relief, but it lasted longer and their function lasted longer. In other words, they functioned better for a longer time period and they felt better for a longer time period without getting that damaging steroid. Another one, platelet-rich plasma versus steroids from International Orthopedics in 2017. Again, platelet-rich plasma gives better pain and function scores versus steroids. Platelet-rich plasma is when we draw your blood. I do this in my clinic too. We centrifuge it at a certain rate of speed for a certain time and essentially sequester the platelets and concentrate them away from the red cells. Then we take those platelets and inject them right where the damaged fascia is. And what does that do? It reverses all of that mucoid degeneration, chondroplastic dysplasia, angiodysplastic bone, when the vessels form where they're not supposed to form. All of those microcellular problems I showed you, the healing properties of the platelets, the growth factors, platelet-derived growth factor, vascular endothelial growth factor, et cetera, start to kickstart the body's healing process. So PRP is a way to do natural healing, not covered by insurance. Systemic review of steroids out of the British Musculoskeletal Disorder Journal 2019. Steroids are less effective long-term than dry needling or PRP, just like these other two studies. They do have the same relief in the short term, and they also have the same short-term relief as placebo or a saline injection. So yes, they can improve your pain in short term, but you probably would not know if somebody puts saline in you versus steroid for the short-term relief you would get, because there's a lot of placebo effect to getting an injection. And then PRP versus steroids, another one. There's so much literature out there that shows PRP is so much better for tendons, muscles, fascia, but to date, insurance companies are still calling it experimental and they don't pay for it. It's very unfortunate, but they will pay for steroids and they will pay for narcotics. So next slide. Yeah, we use dry needling in my clinic all the time. It is, when dry needling came on the scene, I will tell you that was game changing. The physical therapists can cure a lot of problems just with dry needling. Very safe, requires no anesthesia, 5 or 6 sessions and you're good to go, assuming that they're also treating the underlying core problem. Okay, here's another one from 1999 from Foot and Ankle International, which is the preeminent journal in the foot and ankle orthopedic world. So how successful is surgical intervention? So this article is interesting because they didn't just do a plantar fascia release and in this case, they just released a portion of that medial cord. I don't know if you remember the Davers piece. So about, we'll say 30 to 40% of that medial cord they snip. So they leave some of it intact, but they also released Baxter's nerve. Baxter's nerve is a small, tiny branch of the tibial nerve that goes right like that. So it actually goes right to that point and gives your brain the sensory input of that point. So Baxter's nerve, if Baxter's nerve has a problem, your brain thinks it's heel pain. You have no way to differentiate. Only a good clinical exam and a good electrodiagnostic study can really differentiate. But these guys did both. So I'm not sure if the results of this study are because they released the nerve, or because they released the plantar fascia, or because they did both, or was it the placebo effect of surgery, which there's that too. Oh no. They followed these people for almost 3 years. 70% were obese, meaning a body mass index over 30. 39 had severe pain pre-op. Post-op, they said 3 out of 4 of the people, so there were 47, so whatever that works out to be, 75% were pain-free or mild pain post-op. But again, only 50% were satisfied with the outcome. They probably would not have had the surgery had they known this is where they would end up, in other words. So these authors, they didn't say you shouldn't do the surgery. What they said was you should have extensive counseling of the actual outcomes of surgery. Now, to all those people out there listening, I'm sure some of you have had this surgery. We know that because I've had a couple questions. I want you to think back. Were you ever extensively counseled on the actual outcomes of this surgery? Probably not. Again, nobody's at fault here. I'm not trying to throw blame around. Most doctors are way too busy. They don't have the beautiful, private solo practice that I have where I can control how much time I spend with my patients. But you need to think about this before you undergo surgery. Patient satisfaction is likely to only be moderate at best, even if technically that 1 out of 10 VAS pain scale, even if technically you drop from an 8 to a 5, the odds of you being satisfied are not that great. And we're going to go into the costs. I don't talk about the risks of anesthesia to the brain and other problems with surgery, but I don't think anybody should go into surgery very lightly. We have a question, I think.
I was telling Denise that you would be getting to this, but just reiterate, I have had heel pain for several months. Should I see a doctor first or try my home remedies?
Somebody's asking, I have had heel pain for several months. Should I see a doctor or should I do home remedies? I mean, of course, medical legally, I have to tell you to seek professional help, but I am about to talk about different home remedies you can do. Anytime somebody has pain, it depends on how much pain you have, whatnot. It may behoove you to go seek professional evaluation, but I am about to get into some easy, cheap home remedies. All right. Okay, I wanted to show you this picture, again, to talk to you about my philosophy about natural healing and how amazing the human body is and how the plantar fascia is really the core or the foundation to really everything. What this shows you on the left is what's called the superficial back line, and this was work done by a massage therapist, believe it or not, who really developed, and it's been validated and reiterated, this concept, and they used a lot of anatomic basic dissections and proved these thoughts. Okay, this is real. This shows you how connected your fascia is throughout the whole body. So the plantar fascia connects to the Achilles, okay, which connects to the hamstrings, which then connects to the lumbosacral fascia, which then goes up through the back to connect to the occipital fascia. So your plantar fascia is connected to your skull through this very long train. Here's a simple test you can do if you're bored at home. If you stand up and you try to touch your toes and you find that you can't, keeping your knees straight, of course, and then roll your plantar fascia around on a ball for a while, massage it, loosen it up, then do it again, I bet you can reach further. Why? Because you loosened up the core of that long fascial line. So a lot of treatment of plantar fascia, if it's true plantar fasciitis, should incorporate this thought process. So in other words, my physical therapist, we do what's called kinetic chain work. They'll start at the hip and go down to try to treat plantar fasciitis. One of the biggest components of treatment is stretching that heel cord. You can see how thick that aponeurotic tissue is under the gastroc muscle. So the human's a beautiful machine. Everything is interconnected and designed to work certain ways with rotation and movement, force application, and the opposite tension to keep, your limbs from flying off during running and such. But I just wanted you to keep that in mind about how amazing this all is and how foundational good plantar fascia health really is to you.
Some people have had success with PRP. Can you use PRP in all joints?
The question is, some people have had success with platelet-rich plasma, and can you use it in all joints? The short answer is yes. It can be used in all actual articulations, which, remember, a joint is just where two bones meet and move, and they have a cartilage surface that decreases friction and allows smooth movement. So yeah, in a joint, around the joint, the surrounding collateral ligaments, the capsule, platelet-rich plasma is a great modality. All right. So we talked about this. This is one of the issues I have. I mean, I designed this for foot health, and to give your body the chance to heal itself. But a lot of people get it and they think that it didn't work. But a lot of times it's not really plantar fasciitis. The problem is, unless you're in my clinic and I'm examining you, I can't tell you what your true diagnosis is, nor am I really allowed to by little comments online. You know what I mean? It's very difficult for physicians to actually answer questions the way the regulatory environment is. And one of the reasons I do this webinar is so that I can actually teach in a safe way. Look at this slide on the left. That's an MRI. Those arrows are showing you a stress fracture. So sometimes heel pain is actually a broken bone and it's not plantar fasciitis. So if you have recalcitrant, or what I mean is plantar fasciitis, it's not responding to the normal treatments, maybe get an MRI. You might see something like this. Alternatively, you might see a really thick plantar fascia in a normal heel bone, and maybe it really is plantar fasciitis. I don't know, but sometimes advanced imaging is very helpful to get a true diagnosis. The top 5 causes of heel pain, I put this image here for that reason. Yes, it can be plantar fasciitis, but it can also be nerve compression, as we discussed. Look on the right side. That shows you the tibial nerve coming down. It comes right behind the ankle, right behind the tibial tendon. Comes down, one branch gives you medial column sensation and motor function. One branch gives you lateral column sensation and motor function. And then the Baxter's nerve, which is where that blue line is going, where it says nerve irritation. Baxter's nerve goes right under, right at the point of the heel spur, right at the plantar fascia insertion. It could be nerve irritation as the source of your pain. It could be a stress fracture. It could be fat pad atrophy, especially if you've had steroid injections or taken steroids. Or it could be the heel spur, like we talked about, correlated but not causative, but related to pain. Who knows? There's a million reasons your heel could hurt. But true plantar fasciitis should respond to stretching, physical therapy, appropriate shoes designed to help it, in time. If it doesn't, you may want to go seek an alternative opinion. Okay, failure to get better. I put this slide in to talk to you about what I think is an amazing lack of awareness of nerves as a source of pain in the medical community. So this shows you the lumbar plexus coming off the lumbar spine, going through the pelvis, into the leg, going down the leg. So it's sciatica, right? That's just a grouping of lumbar nerve roots that go down the back of the leg. Well, that nerve, the sciatic nerve, splits at the knee and becomes a peroneal nerve, which goes on the side of the leg, common peroneal, which feeds the balance muscles of the leg. And then it also becomes a tibial nerve, which can be compressed anywhere. So I've had a patient a couple times, actually, it's not rare, I mean, it's not common, where their heel pain was actually an S1 disc, okay? It was a disc pressing on the S1 nerve root, and it only manifested as heel pain. I did a selective nerve root block, okay, a spinal injection, heel pain went away. Didn't have to have surgery, they didn't have to do all the physical therapy and stuff, we just got a true diagnosis and treated the core problem. So the nerves, the only reason you ever feel pain is because of an electrical signal from a nerve that the brain processes and interprets. So if you get an electrical signal to your brain for any reason, it can feel like heel pain. So in my opinion, that has to be ruled out as a cause before you go down that whole expensive road of treating plantar fasciitis. So tarsal tunnel syndrome is a great mimicker of plantar fasciitis. I see it all the time. And when you treat the nerve, most times people get better. Okay, somebody had a question about nerve conduction tests and how it might benefit the doctor or the patient. This is a great question. So I have a massive amount of data on nerve conduction studies that I've done over the years for my patients. And I have a group that we were about to write a paper to publish about the false negative rate of nerve conduction studies, till I finally found my current partner now, Dr. Anderson, who comes here to do my studies. She never misses it. If it's there, if there's electrodiagnostic evidence of tarsal tunnel syndrome, she will find it and pick it up. She has a deep understanding of the anatomy. She's technically proficient and very good at this test. And she won't get the same rate of false negatives that most people that do this test do. A lot of times these like EMGs now are done by techs. Software spits out a response, a doctor signs off on the result. That's how it's done in spine surgery. That's how it's done in a lot of places because it's more cost effective for the provider. We don't do it that way because if you don't do these studies just right and you're not really, really good at it, you're gonna get false negatives. So for my purposes in my clinic, I love these studies because it really tells me if there's a contribution from S1, is there a compression behind the knee? Is there something else going on? Like I can rule out a lot of things and then say, yes, it's tarsal tunnel or not. But if it's not a good study, it's effectively a waste of time. So I don't really have a great answer for you.
Could plantar fasciitis be a result of repeated L5-S1 herniation and surgery?
The question is, could plantar fasciitis be the result of repeated L5, S1 lumbar disc herniations and surgery? So the answer to this is, if it's true plantar fasciitis, no. But odds are your heel pain is probably not true plantar fasciitis in that setting. Most people that have a nerve tension problem to begin with, usually it's a nerve issue. So I would not rule that out in that case. I would try to get a good EMG by somebody that knows what they're doing and rule it in or out. Or the other option is to do selective nerve blocks. So you can actually put lidocaine at the tibial nerve above the pain point and see if that helps. There's different little tricks to the trade, and there's different physical exam things you can do to test the nerve versus the fascia. So I think that you're thinking right. It's probably related, but you just need to get a really good physical exam done. Okay, so let's talk about the downsides of surgery and injections. We more or less talked about this, but I do want you to think about this. Nowadays, in the world of high deductibles and terrible insurance plans, surgery and injections are not cheap. You might think they are, but they're really not. And we're going to talk about that. They do require extensive periods of rest and recovery time, as we've discussed. Most people after plantar fascia surgery are asked to stay off their foot for anywhere from 6 to 8 weeks. Well, guess what happens while you're immobilized and while you're non-weight bearing? Other collagen bundles degenerate and become painful. Can't tell you how many times I've seen Achilles tendinosis develop from being in a cast for something else. You can experience negative results later, like all of the complications of surgery and steroid injections we talked about. And there's no guarantee of relief. Of course not. That's why you sign consent forms with us, right? We can't guarantee a result. So don't go into these things lightly. And then the downsides of self-diagnosing. So this happens all the time. We've already talked about how sometimes doctors get things wrong, and presumably we've had a lot of education in this world, right? Not that we're any smarter than anybody else, but this is sort of what we know. And even we get it wrong a lot. So, you know, I don't trust myself to figure out what's wrong with my car, although a lot of times I don't trust my mechanic either. But I'll bring it to different mechanics, right? Maybe you should get multiple opinions, or maybe not trust yourself so much because you might be wrong. There's always that possibility. So let's talk about costs now. This is interesting to me in today's world. So the typical costs of treating plantar fasciitis. Now remember, this is bread and butter for a lot of physicians out there, a lot of podiatrists. So they're not going to want to hear about anything that might reduce this, because look at these numbers. So out-of-pocket costs with insurance for a physician visit. Now, you could have a high deductible plan. You could be paying a higher premium. You could have a high co-insurance. You could have a low co-insurance. You could have high co-pays. You could have low co-pays. All of this is variable, so I'm giving you a range based on your insurance plan. The copay for a doctor's visit could be $50 to $150 every time you come. The co-insurance, meaning the 20% that the 80% the insurance doesn't cover if you don't pay copays, can be anywhere from $50 to $500, and that depends on your deductible. So like my insurance plan personally, we have a $7,000 deductible. What does that mean? Until I spend $7,000, Blue Cross Blue Shield's not kicking in anything, and that's on top of the premium I pay. So I would, if I had to go see a doctor for heel pain, I'd have to pay the cost of the visit, which is really going to be about, with an x-ray and everything, probably around $300. Injections cost anywhere from $100 to $300 per shot, okay? And a lot of doctors want you to do a series of shots, okay? So that can be anywhere from $300 to $900 for what? What did we talk about already? Maybe a month of relief. In some cases, you get a little bit luckier. But all those side effects we talked about. Special shoes, I'm talking about like the New Balance and things like that people recommend. Those can be anywhere up to $300. Orthotics, the ones at Good Feet, I've had plenty of patients come in and show me orthotics that cost $1,200. Custom orthotics done at podiatry offices, anywhere up to $600 to $800. Physical therapy, huge fan, huge believer in physical medicine. I showed you that fascial train, talked about the human machine. But for some people, it's unaffordable. PT can be $20 to $150 per session, depending on your insurance, right? And then surgery, on average, is about $10,000. So the treatments that medicine offers are not cheap. and they're not without side effects. My favorite's physical therapy. I love physical therapy because it's safe, it's effective, and usually the physical therapist can actually fix a lot more problems for you while they're fixing the one problem if they're good, because they'll notice that your hips are weak and they'll work on that, and that's going to help everything. So physical therapy has a lot of intangible benefits we don't talk about when you're talking about the diagnosis you send them for. But I think of all of these, physical therapy is probably the most cost effective, but still not cheap. So what can you do on your own? So stretch your plantar fascia and really your heel cord on a daily basis. There's a lot of literature out there that shows that a lot of foot pain is really because of a tight heel cord. So if you can just keep your heel cord flexible, you will be preventing a lot of problems in your future. Reduce the inflammation or the inflammatory type pain with cold compresses. Keep a water bottle frozen, roll your foot on it, alternate with different types of balls and density, and we're going to show you a video in a minute. And then choose good footwear. We already talked about footwear that won't irritate the condition. And I really like footwear that allows your foot to move like a foot and to use the foot muscles so you can maintain the core strength of your foot. So here are the stretches. This is a video, and you can find these on our website. You don't have to remember these right now. This one here, simple. You can do this before you get out of bed in the morning, obviously. Just take a towel or a sheet and literally stretch. And see there, I'm bending my knee and extending at the same time. So you can put a little bit more stretch on the soleus, and then you can straighten your leg, put a little bit more stretch on the gastroc. And you can also stretch your hamstring that way. This is tissue specific. That is pulling the big toe up and engaging that wind loss mechanism. You can actually see the plantar fascia tightening. That'll specifically stretch the plantar fascia, and you sort of sit like this, figure of four, and do it. Rolling a ball. Now, you might want to start with a tennis ball, a deflated tennis ball, then go to a fully inflated tennis ball, then go to a lacrosse ball, then go to a golf ball. There's different gradients you can use to give a different level of deep tissue massage for those core muscles. Those are some simple things you can do at home. Here's a picture of dry needling. It looks like medieval torture, but I swear this has just been game-changing. It is like magic. It basically does targeted deep tissue stimulation of healing. And it, I think of it like target bombing. Target bombing versus cluster bombing, if you're thinking about it in a military way, which why would you, but I do. This really targets like the flexor lucis brevis, the quadratus plantae, the abductor lucis muscle belly, and they can stimulate the fascia to self-heal as well. There's some low dye taping going on in the top right. So for people that are really active and don't have time to slow down, taping is a great option because you can just keep going and give yourself a little bit of extrinsic support while you're healing. And then these are a list of other treatments that you may or may not have heard of. Shockwave therapy, like large volume shockwave therapy. There's some studies that show that this is somewhat effective, but again, not much more effective than placebo, definitely not more effective than PRP. It usually requires anesthesia. It usually requires multiple sessions, very expensive, not covered. Ultrasound therapy, that's usually done in conjunction with physical therapy. So if you have a good physical therapy program with your insurance, you can get that covered. Amniotic injections. Now, this is something that we've been doing in our clinic that Medicare is actually covering right now. It's from donated amniotic sacs after live birth. Normally, those would get thrown away. Now they're processed and used as a natural medicine. That's been pretty effective. Platelet-rich plasma stem cells. We do that here in my clinic too. Again, because it's natural healing, very effective. No real downside except that insurance doesn't cover it. Prolotherapy, this is an interesting one. It's basically injecting like sugar water, think of it. It's using osmotic gradients of the density of molecules in a fluid cell to try to treat a condition. There's some decent studies on that. I'm not going to poo-poo it. I think it's a reasonable option, but again, multiple sessions, pricey. Custom inserts, we already talked about that and why you may or may not even want an insert, plus they're pretty expensive. And I do custom inserts for people if they're indicated. And then physical therapy, which we've talked about. There's your dry needling. Huge fan of physical therapy. We have a question.
How many minutes for cold compresses, and can it be done daily?
Yeah, so the question is how many minutes would I do the cold compress? And I assume they mean rolling around on the cold water bottle. And can I do it daily? Yeah, you can do it daily. You can do it multiple times a day. You know, generally when we tell people to ice something, we say 10 minutes on, an hour off. And that's just because we don't want to be accused of telling people that we cause frostbite. I would say just do it a few minutes. I mean, it's going to be cold, so you're not going to like how it feels. And you don't want to damage your skin, but maybe 4 or 5 minutes a couple times a day.
Does physical therapy fix nerve pain?
this question is somewhat related. Can physical therapy fix nerve pain in the upper thigh? The short answer is yes. We do that all the time here.
And then Bonnie would like you to discuss massage.
Okay, somebody wants me to talk about massage. Massage is a great modality. It's natural. It uses the fascial meridians, employs physical medicine, but again, not covered by insurance. So you notice a theme here. Anything natural, anything that has no side effects, anything that's like awesome, like massage, insurance isn't going to cover. But massage therapy, particularly foot massage, going up the kinetic chain that we talked about and the muscle train, that fascial train, I think is a great option. We have another question.
If you have issues with the nerve in your shoe, it will help us.
This question is, if you have issues with the nerve, so I'm presuming they mean tarsal tunnel syndrome or that Baxter's nerve or jogger's nerve, can this help them? And the short answer is no. And I tell my patients that all the time. This will help the rest of their foot health and it'll help them recover and it'll lessen tension on Baxter's nerve. But if your compression point, if your bad point is up here, right, if this is the source of the pain, nothing that you do down here is going to matter unless you are sold a rigid insert that's pushing on the nerve, in which case you'll make it worse. So the short answer is no. More questions? Okay, so let's talk about mechanical treatments. We already talked about one of them, if you remember, physical therapy and massage, really so too. The human body is an amazing, complicated, intricate, highly coordinated machine. Okay, if one thing goes wrong, you could feel it somewhere else and not even know about it. Think about how effective hormones are. One hormone screw up and you're going to feel it everywhere. I'm sure a lot of you watching this have hypothyroid or hyperthyroid or estrogen or testosterone deficiencies. You know what I'm talking about. So the mechanical system of the body is no different. So this is a mechanical treatment that promotes natural healing. It's safe, it's easy, you can use it at home, it's repeatable, and it's low risk. That's why I did it. So what is a mechanical treatment? A low risk of complications, very accessible to people, meaning it's easy to achieve. You can get to it. You don't have to drive somewhere, park, hobble into a clinic, pay a copay, sit in a waiting room, fill out paperwork. You know what I'm talking about. And it has a high capacity to relieve mechanical load stresses. So the whole goal of a mechanical treatment is to use mechanics and physics to alter the load pattern that is causing or exacerbating the pain would be a better term. So for instance, this is a mechanical treatment that uses the mechanics of the foot, the biomechanics of the foot, to promote and allow for your body to heal itself, so it empowers you. And this is a picture of a rocker bottom sole, okay? And what it's showing you is that the right side is the back and the left side's the front, okay? With a rocker, which you can sort of see that this is a bit of a rocker, you'll heel strike, walk through, and the shoe does a lot of the motion for you, right? So you're going to go like this, and then it eliminates a lot of need for joint motion here. It helps support that plantar fascia when you're tightening up that arch. So there's a lot of different tricks, and we've used rocker bottom soles in medicine forever. There's a lot of different little mechanical tricks that you can employ to treat these problems, this fascial problem. And what I did was put a bunch of them into a single device that you can use over and over again. But you can get it with other rocker bottoms too, of course. You can go to a cobbler and get a pair of shoes modified with a rocker bottom if you want, if you can find a cobbler. We have one here in Baton Rouge. I'll give a throw out, Militello's. He's amazing. And I send people to him a lot to get things modified and corrected. So active relief with the healing sole. So this is somebody, there are a lot of questions about the healing sole, so I'll talk about it real quick. What I did was, remember I told you I'm not a big fan of squishy shoes because you eventually, the closed cell foams get destroyed and you're not really doing anything to improve the core strength of your foot with things that are too soft and squishy. So I made this a structural shoe. So this is a dense foam. It will compress with wear, and after you break it in, you'll notice that. But it lasts longer and it gives a little bit more integrity to what you're walking on and lets you build up your foot muscles, okay? And then it's got the rocker bottom sole, and I have here, instead of a large arch support, like we talked about, remember how sometimes that can make the problem worse? What I have instead is what's called a metatarsal bar. And so the ball of the foot will actually sit behind that, right? Here's the ball of the foot, the fat pad there. So this effectively offloads the ball of the foot and gives you a little bit of relief. This works really well because it's combined with this rocker and the stiff sole. So it sort of lets you roll up, and it takes a lot of tension off the structures of the foot. The inner heel, so I made it so that it's only really compressible here. Wait, I'll show you on this, easier to see. Here where the heel spur, so to speak, or Baxter's nerve is, it's not so compressible here, okay? What I've noticed over time is a lot of people will have such bad heel pain that they guard, so they're walking on the outside of their foot. You know, they're walking like this all day. And then they start to get a perineal tendonitis or lateral column foot problems or muscle problems at the leg. This lets you take a normal heel strike, but you're still offloading here. This is a problem I have with shoes that are memory foam the whole way over, or the gel inserts, because you're effectively, it's not a differential in the offloading, right? It's all squishy. So you're effectively still putting as much pressure on the zone of discomfort. This eliminates that problem. So all these features together are going to let you sort of strengthen the core muscles of the foot, because it's a flip-flop and you have to, right? But it's structurally sound. It's got good integrity. It's not floppy. So flop is probably the wrong thing, except that when you do walk, obviously a flip-flop hits your heel a little bit. And it's got the different features that let the body heal itself because it de-stresses it, takes some tension off of the inappropriate tension spots, and then lets a natural stretch occur. So we got some questions. Hold on. I think we have questions.
Yeah, I've only been wearing the flip-flop for a few days, but when I do, I'm having pain across the anterior ankle and the proximal tarsals on one foot. Just keep breaking them in slowly. You have to talk about them.
Okay. This person just sent in a question that they actually have this, and they've been wearing it a couple days, and they notice pain. They said anterior ankle and proximal tarsals. So is that normal, and should I keep using it to break it in? The short answer is yes. This shoe takes a couple hours a day for a couple weeks to break in. I would not give up on it, because at worst, it's going to be awesome for your foot health. But what happens is a lot of us, remember I told you a lot of foot problems are from heel cord tightness, plantar fascia tightness, and foot weakness. Well, this lets you rock back a little bit and then rock forward. A lot of times that puts a little bit more stretch on the heel cord than we're used to. And some people will compensate with altered ankle biomechanics. So it's not unusual to be using your foot in a little bit of a different way. I'd have to see this particular individual walk, but it is not unusual. For instance, when I wear mine, because I wear it when I'm not in my dance goes or I'm having I get a lot of forefoot pain, so mine actually works well for that. I'll notice that I have calf soreness sometimes and a little bit of foot soreness because, again, all I do is work and I'm not out running like I should be or exercising. I don't even do yoga as much as I should be. And I notice that when I use muscles I'm not used to using, it kind of aches a little bit. Same thing's true for ligaments. The extensor retinaculum that runs over the front of the ankle is probably being stressed a little bit more. I would just give it a little bit more time probably. But don't wear this all the time, like alternate with your other shoes. Yeah, it's not uncommon at all to kind of have that break-in period of muscle soreness. Just like it's not uncommon to have soreness and aching when you're starting to train for a marathon. You just got to like kind of bear with it. But, you know, again, I can't give medical advice over the whatever this is. Another question, hold on.
Unrelated to the thing, so they want to know about chiropractic treatment for plantar fasciitis.
Okay, somebody asked about chiropractic treatment for plantar fasciitis. Yeah, if you have a good chiropractor who's safe and won't crack your neck, I would, and I'm probably just got a lot of chiropractors mad. I love chiropractors. I send people to one in town here, John Email, all the time. And then Ashley Blanchard. I think they're great if they're highly trained and if they know what they're doing and if they're safe. Now, if you have the chiropractors that just do work for car accidents, I would maybe not go there. Maybe seek a sports specific or somebody that works with a lot of athletes, because they're going to work with a lot of runners and they're going to see this all the time. And they will probably have very effective physical medicine techniques for this problem. I think that's a good option.
Discuss how if they have issues with the toe post, then will the sandal work for our sandal? Your sandal?
Oh, the question is if somebody has an issue with the thong or the toe post part of a flip-flop, with the sandal work. So we have a version called the Everett. that eliminates the thong, mostly because I found that a lot of my male patients don't like these. There is, yeah, it works just as well. I just did a flip-flop because, so when I first made this, what I did was a lot of my patients wanted to wear flip-flops and they were so aggravated with everybody telling them they couldn't wear flip-flops that I really just sat down and started thinking about this problem. That's when I started all this research, and I thought, well, why don't I just make a flip-flop the treatment? Problem solved, and that's what I did. But a lot of people don't like the thong. And just like anything else, so for instance, when I start running and training, I notice I always get sores right here from the heel counter of my running shoes because of the shear and the blistering, and my skin's not used to it. So a lot of people, when they first start wearing this flip-flop, they'll get like skin irritation here. It's like anywhere else with a shoe. You got to wear a Band-Aid or take a few days off. You got to let your skin get hard, just like guitarists get calluses on their fret fingers. The body will adapt to that if you're patient. This question is, do I think that Birkenstocks are a good shoe? Of course I do. Birkenstocks are a great shoe. It's a cork resin, their material, their core material. I think it started out as pure cork. Then they developed a way to mix it with sort of a oil-based plastic resiny thing. And that is a great material for shock absorption. And they have a long history of having great results. I'm a big fan of Birkenstocks. This question is dry needling like acupuncture? No. The only similarity is they usually buy their needles from the same supplier. So it's a thin filiform, flexible needle. Acupuncture follows the Chinese system of medicine with qi and meridians. So you can treat chronic back pain with acupuncture in the ear, right? Because however that meridian works, and actually Dr. Anderson, who does my electrodiagnostic studies, is highly trained and she does acupuncture. So they follow, it's a whole different philosophy, but it uses the same needle. Dry needling uses that needle to go to do targeted tissue massage and to promote targeted local healing. Or if they're really good physical therapists, like mine, Kristen and Danielle and Corey are, they'll use the dry needles to release fascia in one area to affect a body part in another area. But it's not the same as following the qi.
Discuss how to treat a bone spur in the bottom of the heel.
This question is, how would I treat the bone spur in the bottom of the heel? Maybe this is when our talk cut out, but the bone spur is not causative of the heel pain. It's correlated. So what I do is I treat the true source of the pain. The bone spur to me is irrelevant. So if you can make the degenerative tendon that is engulfing that bone spur more organized, more physiologic, more natural, and therefore less painful, that you don't notice the bone spur anymore. If you could take tension off of it, you don't notice the bone spur anymore. If you can treat the nerve that's actually causing the pain, you don't notice the bone spur anymore. So I don't ever go after the bone spur per se. In rare instances, certainly very rare for plantar fascia, I would indirectly treat the pain outside of the bone spur. I'm not sure that made sense, but a lot of times the bone spur is just there because it's there. It's not the true source of the pain. Another question.
I had plantar surgery with bone heel spur. 9 months later, still having numbness in the area of the heel besides massage. How long could this numbness last?
Okay. So this individual just asked, they had bone spur surgery 9 months ago, and they still have a numb heel. So they still don't have sensation on the heel pad here. I'm not seeing you, I'm not examining you, I didn't look at your op note, but I'm gonna guess that Baxter's nerve got tagged somehow and cut probably, or stretched, or it's wadded up and scarred. And I bet that's why you have numbness, because that heel spur is right next to Baxter's nerve, which we talked about. And a lot of times with the heel spur removal surgeries, it's inadvertently damaged.
How do you or other doctors treat nerve pain? Would I go to see a podiatrist?
How do I or other doctors treat nerve pain? I feel like that's a loaded question. I treat it the way I treat it. I can't speak about any other doctors. I first use physical therapy. Some medicines, I have some natural supplements that tamp down nerve pain. Prescription meds such as gabapentin are sometimes effective. We use physical therapy techniques called nerve glides, nerve flossing, and we really target trying to make the nerve more limber and less responsive to pressure points. Okay, so there's a lot of physical ways you can treat nerve pain, natural ways. So one of the ones I use is alpha lipoic acid, which is a strong antioxidant that's been used in Europe for years to treat diabetic neuropathy. So it's a great medicine for nerve pain. And then we have one out now, a Nerve Health Multi, that uses things like resveratrol, N-acetylcysteine, luteolin, omega-3s, algae. All of these things target nerve pain and chronic inflammation nerve pain. PEA, palmitoyl ethanolamide, is another way to do it. And then the physical therapy, like we talked about. If my patients, like let's say you came and saw me, I diagnosed you with tarsal tunnel syndrome, we would do physical therapy for about a month and you would come back. And if you weren't at least 50% better, I would assume that physical therapy is not going to get you where you need to get. And then we do a nerve release surgery, which is extremely effective with almost no side effects. You know, the worst case scenario is it might not work, and that's rare in and of itself, but none of those other damaging to the foot structure issues. That's a whole nother talk. But really, it should be treated non-operatively first. Should you see a podiatrist was the second part of that question. I don't know. So many times this is missed. I would certainly start with somebody professional, maybe start with a physical therapist or a massage therapist. They're a little bit more in tune with the physical nature of the structures that link in the body. Oh, this is more about the natural supplements. So I don't know if all of you were here since the beginning of the talk, but a lot of these problems are really chronic inflammation and oxidative stress, damaging the microcellular structural integrity of things like fascia. So if you can reduce chronic inflammation and reduce oxidative stress, which is brought on by work, family, life stress, poor sleep, dehydration, also brought about by bad diets, eating a heavy on the omega-6 versus omega-3 balanced diet, not enough phytochemicals because we don't eat enough vegetables, et cetera, et cetera, et cetera. If you can supplement the antioxidant capacity and the anti-inflammation capacity of your body with supplements, you might find that you just feel a lot better in general. And then sometimes arthritis pain, fascia pain just goes away. Omega-3 is great for this. Tart cherry extract, this is a 1,500 milligram tart cherry extract capsule. Take it one at night. You'll find that over time you just start feeling better because your oxidative stress levels are lower. And then any given treatment is probably going to work way better because you have given yourself baseline support against oxidative damage and against the damage of chronic inflammation. CBD is awesome for this. Very anti-inflammatory, very antioxidant. PEA, palmitoyl ethanolamide, that is a natural fatty acid your body produces. Anytime there's tissue damage or infection, it's a way to combat bad inflammation. So we don't produce enough of it. So a lot of my stuff has it in it to supplement. It's been great for nerve pain. Great for tissue pain, really. Do we have another question?
Is there a connection between plantar fasciitis and
the question is there a connection between plantar fasciitis and Dupuytren's? There is, if yes and no. True basic normal plantar fasciitis, not so much, but some people have like Dupuytren's, Peyronie's, different areas where the fascia kind of contracts and congeals. So Dupuytren's, you start ending up like this because the lines of fascia along the flexor tendon of the hand draw up. There is a condition like that in the foot, same continuum. And that's a whole different problem than what I've been talking about today. A lot of times you can treat those with surgical releases, or there's even a way to inject a collagenase, which is a protein that degrades collagen. You can use the side effect of steroids to degrade that, but a lot of times it's a snake venom based treatment or surgical. So that's a little bit of a different, more complex problem. This question is, how do you treat fat pad atrophy? So that's a good question because there's really no good treatment for that. It's irreversible damage. So what I do is we either try to devise an insert that will cup what's left of the fat pad and kind of squish it under the weight-bearing axis, or you can actually get fat injected. So we do injections of cadaver, donated, processed, safe, sterilized fat that has all the growth factors and promotes tries to promote the regrowth of your own fat, but really it just sort of gets incorporated in there and replaces it with at least better than skin and bones, and it gives you some fat pad protection. It's really great for the ball of the foot. So ladies that have pain with high heel wear, this is a great alternative.
I've given a boot for 7 months, still no relief. I've had 3 shots, they didn't work. Considering surgery, what do you think?
Okay, these questions, they get my goat. So this person's been in a boot for how many months? 6 months?
7 months.
7 months in a boot. That means immobilized, not using the normal muscle and biomechanics of the foot in the normal way. And they've had 3 shots, which I have to assume are steroids. So they still hurt, and they're about to be signed up for surgery. What should they do? Again, I can't give you medical advice through cyberspace. I would get a second opinion. Go see a neurologist. Go get a nerve conduction study. Maybe get an MRI. You may or may not have had one already. I don't know. If it's failed all that treatment, if you haven't caused some other problem, maybe it's not plantar fasciitis to begin with. But I don't want to speak ill of anybody, but it never hurts to get a second opinion. I love it when my patients get second opinions. Okay, here's a question about 10X treatment. So this one's an interesting one. This is a device that basically you can use billable codes to do what's called fenestration. So I've done this for people in some rare instances where I really thought that there was a tight contractive fascia. You take a very small blade and you essentially pie crust it. So you poke a bunch of small holes. So you're not really snipping anything. You're just sort of doing a forced stretch. So basically stretches it out quicker than, like, let's say a year of therapy would do. And I'm exaggerating. 10X is a device that does those small poke holes, but they also apply this like suction thing to it. It's a good concept. I mean, all you're doing is effectively like a big dry needling procedure. You could probably get the same effect, I think, from going to a few sessions of dry needling and PT, because remember, they're just putting filiform needles into the area to promote bleeding, promote healing, induce the whole healing cascade of the human body. That's the theory behind 10X. It's the same thing with dry needling, same thing with just needle fenestration. I wish I were in Florida too. Somebody just said that they wish I were in Florida. My mom's there right now. I wish I were there too.
To go back to Emily's question about what she should do, maybe you could just summarize again the whole thing, like your process.
I don't understand that question. I've been asked to summarize my whole process again. I know you guys don't want to hear this whole talk again, but you need a good physical exam. Like, somebody has to actually examine you and actually touch your foot and do some maneuvers to see what the problem is. You need good imaging, weight-bearing x-rays. You need a good history. Sometimes you need to do advanced imaging. If you're thinking it's tarsal tunnel, I can usually pick it up clinically like this. I'll do electrodiagnostic testing to rule out other sources of nerve pain. And really is confirmatory, but you have to have somebody that knows what they're doing. It took me years to find Dr. Anderson, and then I had to take time to convince her to come join us over here. Very rare are you going to find that person that's really good at it. There is a group in WashU University that they have a whole nerve surgery team. They're awesome. But you have to have somebody that's interested in nerves and nerve pain to be able to differentiate between the two, between poorly diagnosed plantar fasciitis and or nerve pain. And then you have to have somebody willing to go the extra steps to figure out, is it a stress fracture? Is it an S1? Is it because my hamstring on the medial side is too tight, it's pulling on my gastroc, and I'm walking funny because of that? You know, there's a million reasons you could hurt. It really just takes somebody that's thoughtful and wants to spend time with you and is willing to actually examine you. This question is it typical to have bilateral plantar fasciitis? I would say yes, because remember, the underlying problem is chronic inflammation, oxidative stress. Now, I will say this. Some people get unilateral or one-leg plantar fasciitis if they have something else wrong on that side. So like they had a total knee put in 5 years ago, a total hip. They had a meniscal tear. They have an ACL instability. There's a million reasons you could be loading one leg wrong than the other leg. Generally, it's bilateral. Usually tarsal tunnel, carpal tunnel, those kind of nerve things are bilateral. So it's not unusual to have it on both sides. Another question.
The quit running a year ago after I diagnosed in Georgia with plantar fasciitis. Found your healing soul on one local site and found so much more help with your local doctors. Been wearing the Everett, love your shoes, they helped. Question: when
Hold on.
does one know when you can resume running?
When does one know when you can resume running? So if you've achieved betterment, like you've gotten through the pain course, and this was somebody kind enough to say my shoe helped, so I appreciate that, thank you. When you start feeling better, so this is a runner, and they were told to stop running, and I guess they haven't been running for a year. So A, remember you're very deconditioned. I would just treat it like you're just starting at the beginning again, and if you're pain-free, do what, like I do when I start running again, because I'm always out of shape, because I never exercise enough, which I should. You walk, and then you add 20 steps of running. You know, you just walk, run a little bit, walk, run a little bit, and then you add more and more and see how you feel. If you can afford it, go get a good gait analysis to see how you run, if there's anything you can correct, or maybe go see a physical therapist to make sure your hips are working correctly with your knees and everything. And then just take it easy. Get a decent pair of shoes. I'm a big fan of zero drop. I think it's a little bit more natural. But again, there's a whole world out there that hates zero drop. What can I say? Zero drop just means the foot's like this and not like this in a running shoe. It's just a little bit more like being barefoot, a little bit more natural. What else? It sounds like you're better. So it's a year, you're not in pain. I would just take it easy and stretch. So I don't like to stretch before activities. I think it's better and safer to wait till you're warmed up and then just do some good stretching after you do the walk-run combo.
She's asking, will you ever be licensed in Georgia? I would just reiterate where you're licensed.
Oh, they want to know if I'm licensed in Georgia. No, I have a medical license in Mississippi, Texas, and Louisiana. My office is in Louisiana, and the way the federal regulations are, I can treat people in Texas and Mississippi through telehealth now, and obviously anybody in Louisiana. But otherwise, people would have to come see me because they regulate it by where the patient is, not the doctor. So in other words, if you're in California or you're in Georgia, that's what counts, not where the doctor is, because each state has their own medical licensing board. So if you're in Mississippi, Texas, or Louisiana, I can treat you via telehealth or in person, or come spend the weekend in New Orleans and come see me.
And ask that question. She said, how would you find a good PT that does dry needling, or should I take a vacation and come and see you?
Should always take a vacation and go to New Orleans. New Orleans can use, been through a lot with COVID. Give it a little bit of time, but I'm thinking next year we'll be back and running. And then I'm just really literally an hour outside of New Orleans. I would say go to your state PT society, or call it, probably not the board because they don't usually know, but most states have a society, and they'll tell you in your region who's around you that does dry needling. Somebody's throwing a shout out for Kuru shoes, which again, I mentioned them. That's a decent brand.
And then we'll be getting Everett sandals in a size 7.
They want to know if we're going to get Everett sandals. Remember, that's a cross strap, not the flip flop, in size 7. Here's the deal with the Healing Soul. It is self-funded. We have no venture capital, no private equity. It is, a mom and pop shop. We're doing the best we can with inventory, but I don't know if you've read about this Suez Canal ship thing. That is a real problem for everybody in the world. Our inventory issues are always kind of problematic. Right now, we don't have the Everett in stock, but we're hoping to be able to purchase that inventory soon. So just stay tuned. I'm hoping within a year we'll get some more Everetts out on the market. All right, I guess that's it. We have another question? Oh, sorry. To wrap it up, again, Well Theory is all the natural medicine products that I employ and use on a daily basis. Now I sort of have found a way to do it myself for my community and my patients. The Healing Soul, we've talked about the Healing Soul, which is my baby, and I love the Healing Soul. And then I want you to just remember this. Your body has the ability to heal. We're here to help. Don't look to doctors like the end all and be all. Your human body's amazing. It is designed to heal itself. All you have to do is help it. So my goal, my mission in life is to empower people to self-heal naturally and in the most natural way possible with minimal to no side effects. That's what this is all about. I hope I helped you to achieve that goal. There's a lot of stuff you can do on your own that's safe. And then if you're really worried, go seek multiple opinions from different types of providers. You may be surprised at the answers you get.
Thank you, but there are 2 questions.
2 more questions.
Do you have an opinion on UFUs?
Do I have an opinion on UFUs? Yeah, so UFUs, they follow a philosophy that I don't particularly ascribe to, which is squishy, big arch support. So it's like a steroid shot. Like, it feels really good when you put it on because it's squishy and it's got that nice, soft, big arch support. But at the end of the day, I don't think it does anything for the core strength of your foot or for how the foot biomechanics were truly designed. Because remember, you weren't designed with something pushing up in your arch. The biomechanics of your foot are supposed to hold that arch there on its own. So UFUs follows a different philosophy. If you love UFUs, what I would say is alternate between the 2, because then at least you'll be using different foot muscles. So Healing Soul, UFUs, but Healing Soul follows the biomechanical principles of the human foot and natural empowerment of healing rather than instantaneous cushiony relief, if that makes any sense.
Any neurofascial massage therapists in Baton Rouge?
Question is, are there any neurofascial massage therapists in Baton Rouge? The massage therapist I usually recommend people to go to is Anna Couture of Trifecta. She does a lot of fascial-based massage therapy. Good physical therapists will employ the same techniques, and good chiropractors will as well. So my PT team can do this sort of deep tissue massage following that. But if you want just like an hour-long, really good tissue massage, that's probably who I would recommend.
Everybody said thank you, but one lady said, yeah, everybody said thank you so much.
All right. Thank you. Thank you so much for spending time with me on a Saturday. I'm glad there wasn't a home football game. All right. This is my team. This is our clinic, and everybody here, they're just awesome. I just love my team. I can't say enough about them. I trust them implicitly. They go to the ends of the earth for my patients, and I would not be where I am without my team. So come on by if you ever have an issue, and we'll do our best to take good care of you.